I'm good. I'm just going to leave if he can't figure it out by now. Okay,
Sure.
good go.
Got it.
Yep.
So Rick is already up there. What about sickle cell concerns? I have family members that I want to assist with this. Okay, yeah, we'll get to it. Let me get started. And then as we get into contraindications and indications and all those things, then I'll answer specific questions. I will try to stop in between, or if there's something that I just wasn't really clear about, Nick will interrupt me and just get me to answer something really specific. So my name's Ed LaCara. I've been using BFR for about close to 5 years now, first on myself and then on my patients. And I use it at about 80% of my patients, anybody that's, and I'll share how I utilize it, but mostly with people that need to get bigger, stronger, or better aerobic capacity, which is, I mean, really pretty much all of us. And I'll talk about when I don't use it with people. So here's kind of ways to get in contact with me. ed@edlacara.com is a good way. If you could follow me on social media, it really, really helps me out. It gives me a little bit more leverage on getting my messages out. I post a lot about BFR and about other things that I do in the clinic, and mostly on Instagram, but a little bit on Twitter and some other things too. So whatever your social media is, give me a follow. My YouTube channel as well, I'm trying to grow because people say they can't find BFR content on YouTube from me. And I'm like, I thought I tagged this stuff right, but I think it has to do with I don't really have a lot of followers. So that helps me out. I'm currently writing a book and it should be done this year. I've been saying that I think for 2 years, but I think I promise it'll be done this year. I am the director of education for Smart Tools. I have a private practice that I co-own in right by Southern Methodist University in Dallas. And we have a boutique, it's a boutique medical. So we do multidisciplinary, we have an anesthesiologist, we have a nurse practitioner. We do, besides what I do from a wellness standpoint, we do medical aesthetics, Botox and filler, we do vitamin IVs, we do injectables, we do sleep meditation, we do red light therapy, infrared sauna, and that's why we call it the Body Lounge. I'm a master instructor for TRX, former director of education for Rock Tape, and a former VP of sports science at 24 Hour Fitness. I've been at the VA in the Veterans Administration. I've been head athletic trainer or director of sports medicine for numerous pro, collegiate, different types of sports teams. My PhD is in sports medicine. I'm also a chiro. My MBA is in transglobal education. So I always try to bring the educational component. And so I'm always interested in ways that people are learning. And now with us going so much online, it's really interesting to see how people can consume this information that is typically only taught live. So any feedback that you have, I'm totally open to it. Ways to make things more clear, I would love. Any questions that you have, I look at and I try to integrate that into my presentation. So let's kind of get started. Blood flow restriction training, a lot of misconceptions about what it is. So what we want to first understand, besides just using BFR and why we use BFR, I think like most of you, you wouldn't be on this right now if you didn't think that exercise was a large component of living a healthy lifestyle. I try to use the foundation of exercise and nutrition should be really where we start, in conjunction with the air we breathe, how we breathe, and it just goes on and on and on. But then it gets into like micronutrition, macronutrition, and it just works its way up kind of the continuum. And I'm taking that from a foundational standpoint that, exercise is something that we need to do every single day in one form or another. Doesn't mean you got to get crushed every day, but it does mean that we need to move our body. And in this society, we're moving less and less. And so I'm taking that as a foundation for, hey, why do I use BFR as a modality? And what does it help me do with not just myself, but with my patients? Exercise, I think, should be the primary way that we rehab people. Yes, I do dry needling. Yes, I do manipulation. Yes, I do instrument assisted. Yes, I do shockwave therapy and do a lot of different things as a manual therapist, active release technique. But I always include exercise because if I don't improve somebody's capacity for the activities that they got injured with in the first place, they're just going to get injured again or not be able to return to those things. And if I truly think exercise is an important part of your healthy lifestyle, I've got to get you back to the capacity that you were prior to you getting injured, and probably above what you were, in order to exceed the demands of the activities that you like to do. And for that, we're always looking for ways to efficiently maximize the benefits. So let me give you a little bit of an outline, and we'll try to keep the questions to where we're at, so that way it allows me to kind of flow. Of course, we can always go back. You're going to get a replay of this probably by tomorrow. It just takes time to upload and then get it on the YouTube channel. We'll send out a replay link. But from an outline, I'm just going to go over, hey, what is BFR? Where did it start from? Where did it come from? How long has it been in the United States? Contraindications, how to choose a device. What pressures do we use? And then I'll talk a little bit about programming, like what are the reps and sets? How do we do aerobic capacity training, those types of things. Okay, so first, what is blood flow restriction training? And by definition, and there's a couple different definitions out there, this is the one that I like. BFR or BFRT is the brief and intermittent occlusion of both arterial and venous blood flow using a tourniquet or tourniquets while exercising at low intensities. And so what this means is that if you look at this picture where Chase is wearing this, and he's got this cuff on his upper arm on the right side, he is basically limiting blood flow into that right arm. Now, when I say limiting, it's not fully occluded. He has a little bit of blood flow going in, but he has no venous return going back to the system. So all the fluid that's dumping into that right arm is staying in that right arm, okay? Now, this was during a class, and I have it only on one arm so he could compare right to left. But typically, I'm going to use the cuffs on both arms unless there's a contraindication. What are other names for BFR or BFRT? Katsu is the oldest and the originator of BFR, and I'll talk a little bit about where that came from. Occlusion training, BFR, just straight blood flow restriction, Delphi, Be Strong, and there's many, many, many more. We're one. SmartCuffs, you'll see lots of different names out there, but these are the primary ones you'll see. What is BFR used for? It's really used to increase muscle strength in about a quarter of the time that would typically take from doing high intensity exercise. It helps to increase muscle size, otherwise termed as hypertrophy. In about 2 weeks, you start to see with regular training. And it can also help increase cardiovascular function. And so from a rehab standpoint, it's ideal. From a strength and conditioning standpoint, it's ideal because I can get people to start to see change much quicker. We all know we jump on a new weight loss program and it takes, 2 months to start to see difference. It's really hard to stay motivated, just like a normal exercise program. But in this case, we can start to see change very, very quickly, which helps to keep people motivated, and it gets people to stay on track. When do we use it? Primarily when heavy loads cannot be tolerated. How do we define heavy loads? Heavy resistance or high resistance is defined as 65 to 90% of your 1 rep max. So if I have a 200-pound bench press, let's say, that's my 1 rep max. That's the maximum I can do one perfect repetition for. High intensity training means that I would train at 65% of that or higher, or at 130 pounds or higher. Okay. Rehab is a great situation to utilize this because when people can't tolerate those high loads, especially when we have injured tissue, we've got to use light loads like resistance tubing, TheraBand, body weight exercises, just straight air squats, no load at all, isometrics. All these things can be utilized with BFR. The difference is when we use low intensity, which is defined as 20 to 35% of your 1 rep max, that's typically our body weight exercises, our TheraBands, other things that we were taught in school. When we use those, we don't get adaptation. We don't get hypertrophy. We don't get strength changes. And that's very clear according to the literature. So we need to be utilizing higher intensity exercises, but a lot of times we can't. So we use low intensity with BFR to mimic high intensity exercise. So hopefully that makes sense. Now, there are exceptions where low intensity exercise can give you strength and hypertrophy changes. Those are going to failure. So if I take a low intensity exercise to failure, I can get adaptation. But with that, we get probably more muscle damage, more delayed onset muscular soreness, other things that go around with it, which a lot of times we can't take the damage due to injured tissue. People can't use heavy loads during the season. So I could use BFR during the course of a season to maintain muscle mass, yet not have to damage tissue. Let's take, for example, somebody that's an NBA player or somebody in the NHL, somebody that plays every other day or so. You can't break down a bunch of tissue to train. Otherwise, they're not going to perform well during their games or their matches or whatever they're doing. But they have to train during the season. If they don't train during the season, they're going to lose muscle mass. And by the time they get to the playoffs, they'll have lost a bunch of muscle mass and they won't be able to perform as well. They won't have the endurance. They won't have the stamina. I remember being a little kid and watching ESPN, and Michael Jordan, of course, like a lot of people my age, was an idol, or somebody that I idolized. And I remember them doing an ESPN commentary on Michael Jordan after every game would lift weights. He would go through a circuit. And I thought to myself, man, the guy just played a ton of minutes. He's got to be totally fatigued and tired. And he goes and he lifts weights afterwards. I mean, that's pretty commonplace now, but back then wasn't. And I thought, man, that takes a lot of just mental fortitude. And when they asked him why he does it, he said, if we make the playoffs every year, we go for a championship every year. If I don't weight train during the season, by the time that the end of the season comes around, my body is beat up. I've lost 10 or 15 pounds. And they'll be very physical with me in the playoffs, and my body won't be able to tolerate it. So he saw the value, and that really put a light bulb over my head. Like, wow, this is really, really important to do. I was a Division I wrestler. I saw the same thing, cutting weight, not lifting as much weights during the season. We would do some circuits and some other things, but I would end up losing a bunch of muscle mass over the course of the year. And if I had BFR back then, I could have done light load training in the middle of the season, maintain my muscle mass. So by the time that the postseason came, I was hopefully as strong as I was when I got into the season. I also maintained my muscle mass, and then I wouldn't have to work so hard in the off season to get back to where I was. Elderly, a lot of times elderly can't lift heavy loads. And so being able to use light loads with people that are deconditioned or elderly can be of great value. And supplementing existing fitness programs. There's some literature existing currently that if you do normal high intensity training and then you add BFR as a one time a week or 2 times a week add-on, you can really accelerate your I'll say gains with a Z compared to just doing high intensity training. So lots of places that we can utilize. What are the benefits? Able to use lighter loads for similar results at higher loads. Little to no muscle damage. This can take us a long way. And faster results than normal training using both aerobic and resistance. Where is it being utilized? Rehabilitation clinics, strength and conditioning facilities, and CrossFit gyms, hospitals. And then now we're starting to see a lot of at-home use. I was a VP at 24 Hour Fitness, so I still have a lot of friends that work in the fitness industry. And they're saying that places or things like online, Peloton, YouTube, people are going to these resources so they can stay home and exercise, because for me to go to the gym could take, by the time I drive there, I get my workout in, I shower, I get back here. It can, it's a 2-hour deal typically. People are wanting to save time, stay at home moms. There's a lot of the population that is looking for alternatives to do at home, and BFR is a great opportunity because you don't need heavy loads. If I show you, I'm going to stop my share for a second, And I'm going to show you basically what I have in the clinic. Okay, so it's hard to see, but I've got a treadmill up against the window. I've got light resistance bands. I've got dumbbells. I've got dumbbells to 20 pounds, and I've got a TRX suspension trainer that I can utilize. And that's, you know, then I do body weight exercises on the table. And that's really all I need. That's enough resistance, 20 pounds of load. Most of the time we're gonna use much, much lighter load. I'm gonna use resistance bands. I still have TheraBand and I still have other light resistance loads that we can use, ankle weights, all those things. So you don't need a lot of load at home, and that can be very, very helpful. All right. Okay, so now what I want you to do is kind of open up your, the handout that I made you. I had spent a good portion of well, more than a day putting this together to be as an adjunct and a kind of a resource for you. I put a lot of links, so these blue, I've tried to put them in blue if they were linked. So if it stays in a PDF, they should go directly to some resources from video, other things. If you are looking for getting certified, like you're a strength and conditioning, you're a personal trainer, you're a physical therapist, you're a chiro, and you want to learn more in depth, we're probably going to teach close to 200 courses this year. Maybe not now, since, you know, we've been kind of put on the burner for a little bit, but you can go on smarttoolsplus.com and you can see all the live courses that we do internationally. If you want help, like you want to find a certified provider by you to help you get started, you can find a certified provider. That's what this link is, or you can reach out to me. I do virtual consults as well. But as we kind of go through this presentation, you know, you can look at some of these notes that I put in here, and these were kind of more of my outcomes. Like, what did I want you to get out of this course? And it's, you know, people will ask you, if you start putting cuffs on and going into the gym, they're going to ask you, like, what are you doing? And so one of the questions I have is, in your own words, what is blood flow restriction training? You should have an answer to that. If your patients ask you, if the orthopedic surgeon that referred you a patient asks you, you should have an answer to that. And so be able to write it out, and then that way you'll be able to just say, hey, this is my kind of canned answer to what BFR is. You know, typically my answer is we can use light loads to trick the brain and body into thinking you're doing heavy loads, get faster results with strengthening and size without damage to the tissue. You know, you can also list like, hey, what are some of the benefits? Where did BFR originate? I haven't gotten there yet, but you can kind of take yourself through. And I try to highlight some items to make it clearer for you. All right, so where did this originate? In the 60s in Japan, Dr. Sato at the time, he was doing some martial arts, and he was sitting back on his haunches, almost like what I would do in wrestling. If it was like a start position, sitting backwards. I think it's called a Geiza position. And he was there for a long time. And what he noticed was that he started to get swelling in his limbs. And when he stood up from that position, the limb was larger than the other size. And he's like, whoa, what happened? And he wanted to see if he could mimic that. So what he started to do is use like belts and straps and bands and try to see if he could mimic it. And then he started to exercise with it. And then about 6 or 7 years later, he injured himself skiing. He tore a few ligaments in his knee. He was told he had to have surgery. And this is a very similar story to what I had. I wrestled in college. I tore my ACL, my PCL, and my LCL. So 3 out of the 4 ligaments were torn in a tournament when I was wrestling up at a tournament up in Oregon State. I didn't wrestle there, but I was wrestling there. And, you know, pop, ligaments torn, told you have to have surgery. And I was able to rehab it with the help of my chiropractor, my strength coach, and my athletic trainer. And that's how I got into what I do now, helping people overcome pain and get back to activities that they love to do. That's kind of my tag. So he, like myself, Dr. Sato had the same thing happen during a skiing accident. But instead, he used BFR and started playing around with some exercises and things. And the story goes, I mean, I've never talked to him personally, but just reading about this, within a few months, he was back being active and didn't have surgery and was able to rehab it. So we started to develop what is now known as Katsu training. And Katsu training has been around since the 70s. I mean, we've only heard about BFR since like a few years. Some of you are just hearing about it for the first time now because it's not that popular in the US, but it's been around for a long time and it's been studied for a long time. Unfortunately, all that Japanese research that's been done wasn't translated to English until about the early 2000s. And then what happened is as people were translating it, people were starting to pick up on it. And then in about 2012 or so, Johnny Owens, a physical therapist out of South Texas, was working at the VA and DOD and was working with people that were having prosthetics done and other things. And what they found is that they were looking for something that drove growth hormone up exponentially in somebody. So somebody that gets, let's say, a tissue reconstruction, like, you know, I'm off in Iraq and I step on a device and I take out a chunk of my skin. Now we need to fill that and cover that with a graft. And so the surgeon might take, you know, some tissue from a glute or from a leg, and then he would patch it on. Well, my body has to accept that as my own, otherwise we reject that graft. If you inject growth hormone into people exogenously, I just take growth hormone and I inject it, that graft will stick. It increases collagen formation in the presence of vitamin C and some other things. So they wanted to find out, hey, if we can have somebody develop and make their own growth hormone, would that help? And so they discovered BFR because BFR drives growth hormone production 3 times as much as high intensity or as regular as baseline and almost double as much as high intensity exercise. So they started using BFR with these people that were having these grafts. And then they saw results. And then they started to say, hey, maybe we should try to do this for people that are starting to get prosthetics. Because if I have a mid-humerus and I've got this heavy prosthetic, this limb might not be strong enough in order to support that prosthetic. So they started using BFR cuffs in the legs and in the arms, and they started utilizing it in physical therapy. And they started to see people were able to get stronger and bigger faster. And so that's really where it's come from. It's only been around since 2012. In the US. I mean, honestly, I was looking in 2015, once I discovered this, for a great resource that was affordable, and there really wasn't one. And that's how we got into the market in about 2015. Well, to back up, I had joined Nick with instrument-assisted soft tissue. Nick had, at Smart Tools, he was graduating from chiropractic school, had used some instrument-assisted soft tissue tooling, and he really liked it, helped him overcome his injury, and he wanted to use those. And the tools were so expensive, he couldn't afford them. I mean, he was in school, tools were $2,500 or $2,000. And he went to his dad, who was in the tool and die industry, and he said, could you make something like this? Because these things are so expensive. And he's made a set of tools, and then everybody at school was like, hey, where'd you get those from? And so it kind of, make a long story short, he kind of developed it, and he was like, man, I can make affordable tools that are FDA listed and of really high grade stainless steel. I came along and made some education and programming around those tools. And we just repeated that with BFR. We saw that there was a great modality that was too expensive for common people, and wanted to create a resource for people to be able to learn about it. And so Nick up in Cleveland takes care of the manufacturing and making sure that we're evidence-based and evidence-informed and using the best products that we can, get them FDA listed. And then I developed the education around it. And I wanted to create a place where people could afford to learn about this because it's such a great modality. I want people to be able to utilize it. And back in 2015, the only choice was to spend about $6,000 for a single cuff and the education. And we just wanted to make something that was more affordable. So that way the trickle down would be, hey, it doesn't have to be just at elite places and at the NFL and in the NHL. It can be in a small clinic like mine, and my patients can benefit from it. As of 2018, the ABTA said it was part of the professional scope of practice for physical therapists. I believe that's in every state except for North Carolina right now. I'm not sure why North Carolina is accepted, but that might have changed. Most large medical systems are using BFR, lots of professional sports, and I've been at numerous universities, including Stanford, teaching our techniques. Okay, let me see if there's any questions just to make sure I don't get too far behind. All right, looks like Nick is taking care of them. All right, cool. All right, so how do we get started? As you can see in your handout, it's really like, have a goal. Do I want to get bigger? Do I want to get stronger? Do I want to increase my aerobic capacity? And that's why I put VO2. If I have a goal of that, then BFR might be a good adjunct or a good modality for you. I want to rule out red flags. What are the risks and what are the absolute contraindications? I should know that. And if I don't know that, or if I'm unsure, I need to get help from my healthcare provider. Then you got to choose a device. And we're going to talk about two. There's some that you blow up and inflate, and there's some that you just put on and it's like a strap and you just wrap it. So there's practical, those are the wraps, and pneumatic that you inflate. You got to figure out how much pressure you're going to use. Am I going to use a practical and just use the subjective, or am I going to use pneumatic and have a specific millimeter of mercury pressure? And there's pros and cons to both. I'm going to choose the exercises and the resistance. With resistance exercises, we typically do somewhere between 3 and 5 exercises in a session. With aerobic training, we do typically 15 to 20 minutes, and you can do that twice a day. And then I'm going to choose a frequency. Resistance training has been shown 2 to 3 times a week with BFR is as effective as 5 days a week. So no need to do it every day. You can do your normal training protocol. With aerobic, we see better benefits at about 5 days a week. So what I recommend is doing aerobic training and separating your aerobic training from your resistance training. Next week on, I think it's Thursday, I believe, or Friday, I'm going to do a 30-day, like, how do I get started with BFR programming, and throw in a bunch of research. And this is why this is my thought process. But what I do is I separate aerobic training in the morning. So I get up, I go for a walk, I try to expose myself to sunlight, try to get vitamin D synthesized, try to clear my head. I might do some breathing exercises. I might do some other things. And then I will split that with my resistance training, because what we know from regular training, high intensity training, is that if I high intensity train after an aerobic session, muscle protein synthesis is blunted. So I don't get as good of an outcome. So I'm not getting the benefits. It's like posting on Instagram and not adding any tags. Nobody sees it. I might get the exercise in, but I'm not going to get the benefits if I combine it within a session. Now I get it. Some people are very busy. You're still going to get a benefit. It just won't be maximized. So that's why I try to separate them. But like, let's say in a clinic, and if I have somebody coming in, they typically get on the treadmill first as a warm-up, I would like that warm-up to include BFR so that it's physiologic. If I don't do that, just walking on a treadmill for 15 minutes is not going to cause change in my aerobic capacity. With the cuffs on, though, that same exercise will cause aerobic capacity. I'll talk more about this later. Risks and contraindications. Answering a question from Misty. I have tons of resources and references. I won't share it right now because I'll have to, but there's tons. They have done numerous comparisons.
Hey, Ed, do you want me to send? I can send her the BFR position paper.
Mm-hmm.
It has those nice graphs that go over.
Yeah, why don't you do that? Why don't you send the 2019 position paper, and if you could put that into the chat with a link so everybody could have access to it, that would be amazing.
Yep.
Thank you.
Yep.
Yeah, the nice thing too is a lot of these things are summarized within position papers, where some of the best minds in BFR have written like, hey, this is where the research is, this is where, experience is. Now, I try to take it from a 3-prong approach. Sackett has talked about evidence-informed or evidence-based medicine. And what that means is that I'm using a 3-pronged approach. 3 prongs mean I look at the best scientific evidence, I use my clinical experience, and I also am meeting my patients' or clients' wants and needs and expectations. So I am combining about 5 years of the best available research, and the research has gone back further than that, but me personally looking through it, the patients' experience that I've had, my personal experience, and also when patients are approaching me and asking questions. So all three of those, patient wants and needs, best scientific literature, and also clinical experience play a role in how I teach and how I perform BFR. So if we go down to, we're on page, I believe this is, I'm not sure what page this is. I should have numbered these pages. I got to remember to do that. You know, we're looking at number one, what is your goal in your handout? And then number two, what is your contraindications? Here's your major ones. I'm going to list some other ones. But before I go through these, I want you to know that BFR has been shown to be very, very, very safe. I mean, there was a review of over 12,000 sessions using BFR, and the incidence rate of injury is ridiculously low, like less than 0.01%. So although I'm going to show you some risks, these risks are very, very minor, and you just have to take some little precautions. Now, if I would say that 99% of the people that have been cleared for high intensity exercise are also going to be cleared for using BFR. So that's like, hey, they're cleared to do high intensity exercise, they can do BFR. Then we're going to have a small subset of the population. Now, for some of us that are constantly working with cardiovascular patients, that seems like a lot higher percentage of the population because that's all you see, right? Like, if somebody asked me how many people in the world have, you know, musculoskeletal problems, because that's all I see in the clinic, I'd be like, man, everybody has musculoskeletal problems. Now, we know that it's a high percentage, but because I'm only exposed to a large amount, it seems like that percentage is much higher. Same thing with, hey, I'm seeing that uncontrolled high blood pressure is a contraindication to BFR, and that's all I see. Well, yeah, so you're going to have to take a lot more care with the type of people that you see, and make sure you're doing blood pressure readings before and probably after to see how they tolerate. You're probably going to have to undercook them, a term I use for not doing as intensive exercise or not using as much pressure. And so you're going to take some precautions. But what I want you to take home from that whole little, 2-minute rant is that it is very, very safe. And if you have any concerns, collaborate with their primary care physician or their cardiovascular surgeon or their cardiologist. If you're using it for yourself and you're unsure, get with a certified provider to help you or talk to your primary care physician. All right, so what are we concerned about? We're concerned about thrombosis, we're concerned about cardiovascular stress, and we're concerned about injury from tourniquets. So kind of those three big categories. So we're going to talk about all three of those. Thrombosis is typically caused by occlusion of blood flow or stasis. So this guy Verschow has a triad. He talks about stasis of the blood, like when does stasis occur where you could start to get some clotting? Well, think about when do we get deep vein thromboses? And the number one thing that I see is travel in a plane, long distances. So if somebody has just come from Europe and they're in your clinic the next day, or you just traveled, I would wait a few days before getting, before using BFR. Nick and I traveled to Dubai a couple of years ago. And guess who got a superficial venous thrombosis? Me. I felt it. I got off the plane, and it felt like somebody kicked me in the calf, and I was like, "What the heck?" And it hit me right away, like, "Oh boy, I think I got a clot." And it was, it happens. I mean, so you just have to be aware that anytime that you're in a situation where you have stasis, then you're going to take more precaution. Other times that I see where the biggest risk is right after surgery. So there's a 100% increase in DVT after extremity orthopedic surgery. I would take caution of utilizing this in somebody that has pre-existing condition. I had a guy from Stanford who I treat. He, in the third game, he's a starting left tackle for them. third game he's playing, he breaks his ankle, he has to have surgery, ends the season. He developed a DVT. Here's a young, top probably 1% athlete in the nation, full ride scholarship to Stanford, healthy. It occurs. There is an increased risk there. Just be aware of that. If the person is not as healthy, then I would wait. And the recommendation right now is somebody that's older that has possible contraindications, you should wait 3 to 4 weeks before implementing BFR. It's not going to change the outcome over the course of a lifetime. Yes, he might have a little bit of atrophy in the meantime, but it's worth waiting a little bit if you have any question at all. Paul's asking, any contraindication for a patient who has a chronic DVT? And the answer would be yes. You want to, like I have a patient right now that I would love to use BFR on. She needs it. She has a 360-degree cage from T2 to S1. I mean, I need her aerobic capacity to be up. I can't use it. She has chronic DVT. I'm not willing to take the risk. She's on blood thinners every single day. And if she's not on those blood thinners, she develops a DVT. I don't use it with her. She's just not a great candidate. Christopher is asking what type of caution should be made with patients under 15. So we don't recommend, except for like extreme circumstances, that anybody under the age of 15. And here's my rationale. You're never going to get an institutional review board to allow for testing of an adolescent under the age of 16 with BFR. There's been some high school studies that have shown good strength and conditioning increases with BFR. I'll have to go back and look and see what age. In most cases, less than 15, it's not going to be necessary unless they're just a super elite athlete. Like if they're a super elite athlete, they're going to the Olympics, they're doing something, then I might consider it. I would have an honest conversation with the patient, but also with the parent, and get the pediatrician on board. We don't know. We just don't know. It's not been studied really. Like what happens when you spike growth hormone in an adolescent, almost double with high intensity over a high intensity exercise? We just don't know. So I would use caution with anybody under the age of 15. And if you are going to do it, they should be at least 14 and a half in elite athlete, and making sure that they are, that everybody's on board, that you're not exactly sure. Do I think there's going to be a problem with it? I honestly don't. Have I used it with people that are 14 and a half, that are a one sport athlete, that are pretty elite? Yes, I have. But I had a conversation. There's a separate release form that I use for BFR. Like everybody needs to be in the conversation. Rick's asking about sickle cell. I've seen some publications that say sickle cell is a contraindication because of the hypercoagulability component and lack of oxygenation. I think that if you're using it for short periods of time and they are, if they have the sickle cell trait, I think you're okay. If they have full-blown sickle cell, I think you're gonna have to keep sessions short. You're gonna have to keep pressures as low as possible. And you're gonna have to keep exercise dosing low, like 1 or 2 exercises. I would start with 1 exercise, see how they do, because you're having the carrying capacity of the oxygen is limited. Plus, you're already in you're putting the cuffs on and depriving of oxygen. So, I would look at some of the references for safety in BFR, and you come up to your own conclusions. But I would be very careful with sickle cell. Primary lymphedema. Primary lymphedema, it's really about how swollen they are. I've used it with lymphedema patients. The current recommendation is to not use it if there's excessive swelling. Again, conversation, light pressures. The reason that it was a contraindication. I told my patient that's a contraindication. She's like, please help me. I'm losing muscle mass like there's no tomorrow. I can't do anything with this arm. I want to do something. And so I used passive BFR with her, which is a little bit above the scope of this course. which is I just put the cuff on, there's no exercise, and I use e-stim to do contractions in order to drive muscle protein synthesis. It's something that we use when people are in a cast, when they're bedridden. And so we were able to maintain and get a little exercise in there, isometrics, things like that. If you're already using exercises, you have that waiver, you talk to them about it, and you undercook them before you overcook them, there should be no problem. I think I answered the sickle cell. I think I answered this. Primary lymphedema. I haven't seen thalassemia as a contraindication. Again, I would look at, I'm trying to think. I have not seen it. That doesn't mean it doesn't exist. It just means I haven't seen it. So I would look at a review of the literature. And what I can do is I'm going to take a note and send the most current review of the literature for safety. And I'll send that all out to you guys. Okay. Okay, contras for exertional compartment syndrome. Not that I know of. If it's acute and it's swollen, what I use is, I'm going to get to it, but excessive swelling is a contraindication. So to me, excessive swelling is somebody comes in and they've sprained their knee and it's 2 inches larger than the other limb, the non-involved limb. I work on getting the swelling out. I'm not worried about BFR. I get it less than 2 inches and now it's no longer severe swelling. Nobody's ever quantified severe swelling. So that's what I use, less than 2 inches from the good or the non-involved to the involved. So with an exertional compartment syndrome, I have used this with casts, plaster casts, a lot, and I just kind of monitor it. If they start to feel symptoms above a 7 or 8 out of 10, I reduce the pressures. So you're gonna have to monitor the pressures, but it is a nice way to maintain muscle mass with people that are in a cast. And that's what's called a cellular swelling protocol. It's a little bit above and more of a clinical, so it's not what's really enclosed in this 101, but you can get with me offline and I'm happy to answer. More on timeframes after surgery that would be safe. Brian, so the hard part is that I have patients that are ACL that are young that I'll start next day. If they're young, they have no contraindications, there's no problem with that. If they're young, healthy, young meaning, 35 and younger. If they have any contraindications or risks, I will wait probably 2 weeks, and I'll wait if they have a scar that's bigger than 2 inches. The reason that if they have a scar bigger than 2 inches, myostatin is downregulated. When myostatin is downregulated, our ability to form scar is reduced. So you've got to wait. Let's see. Contraindications. Nicole, I don't think that there is any contraindications for increased risk of bleeding. Again, we're really looking for things where there's hypercoagulability, not hypo. So I think you're going to be okay. But again, double check in some of these literature reviews. Contraindication who has, yes, active cancer is currently a absolute contraindication, which I'm trying to get to. If they're in remission, no problem. Do you have to worry about medications such as Adderall? I can't think of any reason why. The worry you're really worried about is people that are, there's two situations where I'm concerned with medications. People that are taking an anticoagulant, that means they have hypercoagulability, right? Not like a baby aspirin, but hypercoagulability. And the other thing that I'm concerned about is hormone replacement. I've had patients come in that are on, like they have pellets. In Dallas, it's a big thing. They'll have like a testosterone pellet implanted in their belly. I always check hematocrit levels with that because higher hematocrit levels, they're making a sloshy blood. It's more viscous. So anything above about a 55 or 56 hematocrit, I use that as a risk factor, and I make them dump their blood or give blood about every 60, I think right now it's every 63 days or 61 days they can give blood. I think giving blood is a really good way for our body to have to remanufacture. It's almost like a forced apoptosis. It forces our remaking of new blood cells, but it also will drop that hematocrit. And we try to bring in into the clinic once a quarter is our goal to get to contribute blood to the community because we need it, but also for the health of our patients in order, even if I'm, I like to give blood just for the health of it. I think I answered live. So can I combine neuro-re-ed? Absolutely, do it all the time. It's a really, really great way to get type 2 fibers using neuromuscular re-education and electric stimulation at the same time. How will we know how much pressure to use? If you remember my outline, I said I'll get to pressure, so just kind of hold that. I promise I'll get to it. Is there any way to check if the patient has a DVT? Well, you'll know because of pain. Look at the, what are the findings with a DVT? Hot, swollen, lines in the skin. The best way to know is with a ultrasound. But you'll know with the symptoms. I mean, it feels like you got shot in the calf. Somebody comes in with unexplained calf pain, like they strain their calf. Now, it can be anywhere in the body. It can be in the upper extremity. It's just very rare. But somebody has unexplained pain, there's no incidence, your alert should be up. Like my red flag is like, huh? Like, how did you do this? And they're like, I don't know. I just woke up with this calf pain, right? And I'm like, okay, well, when's the last time you had a long flight? And then I started looking, making sure in their history I didn't miss anything. Are you using a separate BFR release form? Yes, for all patients, Michelle. I think I have that in my course next week where I share that with everybody. I have a long form and I have a couple short forms that you can use. Of course, it's done in Texas, so you have to have your own lawyers depending on what state you're in. But I would have a release. Hello, and thanks for seminar. What about acclimation? Is it never necessary to do passive BFR for acclimation? I'll get to that, but I'll leave it up here. How early can this be integrated in postoperative rehab, such as ACLR? Same day, next day, typically they come in, or 2 days later. In a young adult, I think I answered this. With a young adult, no contraindications or risk factors, it can be started right away. As long as the scar is not like mine with the, big zipper, nothing bigger than 2 inches, it can be started right away. While in a researching BFR and aerobic component in Indian adults, the most common contraindication was fainting at application. Fainting at application. Yeah, that can happen for sure. And I've made people lightheaded, especially with isometrics. And the reason that it happens is that when you cut off blood flow, what you're doing is you're reducing stroke volume. And I'll talk about this during aerobic capacity training, but if you reduce stroke volume, what has to happen? In order to maintain the same cardiac output, my heart rate has to go through the roof. So people that are very, very deconditioned, you've got to undercook them. It takes like 3 or 4 sessions for people to get used to BFR. And so you've got to undercook them, 1 or 2 exercises on a table, do passive. Depends on, how much they can tolerate and how athletic they are and if they've ever done BFR before. But you definitely have to slow roll people into it. I think I just answered that. Nancy, would that include HRT for women? Yeah, I would be cautious of coagulation, and I would look at their blood panel and make sure that they don't have it. Most don't. I mean, this is a very rare finding, but just be sure. Make sure that they don't have any increase in hematocrit. Kevin, I'll get to the differences when I get down to how much pressure to use. Victor, I use this all the time with neuroscience and symptoms like sciatica, TOS, carpal tunnel, drop foot. I use it all the time with these things. It's because I'm able to either utilize E-stim with the cuffs and get type 2 activation that I would never be able to get. Now, there was one study looking at, hey, if I only exercise with the cuffs on my limbs and I don't do specific lower back exercises, do I get any change in multifidus and in core? And you don't get increases in size, it looks like. There was only one study, hasn't been validated. So what I do is I do combination, like I'll do BFR. If I'm trying to get hypertrophy of multifidi, I will have people do like walking protocol first, and then I will go, because what that's going to do is going to drive growth hormone, drive muscle protein synthesis in the lower limbs. And then I will separate and try to have them doing specific lower back exercises. So it looks like you can't, according to the current literature, you can't train legs and expect changes in cross-sectional area of the core. You still have to train core specifically. Now, with that said, there's been studies that were released last year comparing doing specific core exercises to doing just general fitness. And what they found was that outcomes were very similar. So I tend to go specific with, hi. Can't do it. You need to, hey cop, I'll do it. Just give me 1 minute. I need to step out and do and do something for somebody, but I'll do it. Just give me 1 minute. When you're utilizing the cuffs, we can do things to try to drive more growth hormone, and for the core, it looks like we have to do specific exercises like core, like planking and bird dog and those types of things. Nick, will you answer the next question? I'm going to step out for just 1 minute. I got to do something. I'm at the clinic. I'll be right back.
Sure. Victor, I believe we left off with Ed asking, can you hear me okay? I'm guessing so. Yeah, regarding neural symptoms, sciatica. Yeah, with TOS, you don't really want to use cuffs on the upper extremity with TOS or carpal tunnel, just because you don't want to run the risk of injuring those nerves since they're superficial. Ed, I'm not sure if they heard me or not.
I'm back.
Okay.
What was the question?
Regarding the neuroscience and symptoms, sciatica, TOS, and carpal tunnel. My video did pop up, so I wasn't sure if they heard me or not. But
I think I answered that too.
Yeah, it's just the superficial nerves. You don't really want to affect those. But
they said Nancy said they heard. Hi Nancy, how are you? Okay. And then let's see, is BFR useful for sarcopenia? I mean, I think that this is made for sarcopenia. I mean, sarcopenia is a muscle wasting over time, typically not only due to our inability to utilize the protein that we intake as we get older, but lack of resistance training and not lifting heavy enough loads. If anything, what you should do, and I'll send out a link for this, is somebody that's really big into this is Joe Marcola, Dr. Marcola. And he and I did about a 2-hour podcast a few months back. And he loves BFR for sarcopenia. Maisha, I'll get there. There's BFR and calf strengthening. We're going to do programming in a little bit. Let me keep moving forward. So again, we're back, just kind of coming back. We are at contraindications. There's been numerous studies looking at thrombus risk, and what it appears is that exercise actually makes antigens to reduce coagulability. So if you look at BFR compared to high intensity training, this is a Clark 2011 study, we saw this TPA antigen was increased. So it might actually be preventative. So just keep that in mind. I don't think that we're at an increased risk. I think if somebody gets it, it's kind of like if somebody gets they're just really utilizing either too much pressure. If you follow the way that I kind of teach it, you're doing it in a safe and evidence-based way. And if you use cuffs that are wide enough so you don't need as much pressure, you're going to be much safer. But I'm going to talk about that a little bit when we get to different types of cuffs. And here really is tourniquet injury. What is it caused by? Prolonged duration. We don't recommend anything more than about 20 minutes. Using a very narrow cuff, and a narrow cuff is defined as less than 5 centimeters. If you use extremely high pressures, and when do you have to use high pressures? When you use a narrow cuff. So use a wider cuff, greater than 5 centimeters. It allows you to use less pressure, which then improves the safety. And then direct skin contact. Some people get irritated from the cuff. So I'm gonna stop a share, and I'm just gonna show you what I use in the clinic. So this is a dual ply sleeve. And what this is what we use in the athletic training room when somebody sprains their ankle and you want to put something on there to compress, like a tensor. And so I've got this, and then I'm just going to put this in the upper extremity. I put it up here. And then I'm going to put the cuff on top of that. Okay, so that's what it would look like. In the lower extremity, you would put the sleeve up here, and then you would put the cuff on right there. And I'm going to talk about where you put the cuffs and all that, but not everybody has to have a sleeve. If you have, kind of like thinner skin, it's better. Some people get irritated from it, and there's been one study that I can recall that looked at single ply versus dual ply. And I think in this environment that we're in right now, I think all of us are going to have to really up our game with hygiene. I knew the hospitals already do this, and you have to have protocols and all that with cleanliness. But I think the less you can have skin contact with any of our modalities, and then you have your cleaning protocol in place, the better it's going to be. So if you have something that you can wash, better yet, patients would have their own, maybe you sell it to them and it is part of their package. And then you wash these in between each patient by wiping them down. I use a clavicide wipe. I wipe them down, and then every night I wash these with soap and water and hang dry. And that is what's in our protocol manual. Any questions about that? So using tight shirts are fine. Yoga pants are great. But sometimes skin can get irritated. So I do have a question here about would these specific BFR cuffs cause any superficial nerve damage? Have I had any cases personally? What are the signs and symptoms? Well, signs and symptoms would be any type of like mimicking a radiculopathy, hopefully not muscle weakness. I think it would start off as, like a numbness and tingling. There's been numerous studies looking at NCV of the nerves like weeks post starting BFR, and there's no reduction. There's no risk for injury as long as you keep the pressures low. Like if you look at this study by Crenshaw, looking at how to get pressures with an 18 centimeter cuff versus a 4.5 centimeter cuff. I mean, the wider the cuff, the less pressure you need. It's why we developed the cuffs the way that we did, is to make them wide enough so that you don't need as much pressure. Narrow cuffs are going to be more uncomfortable, and they're going to be higher risk. They're going to have to be inflated much higher. Okay, so here's your risk categories. I'm going to let you read through this. I don't think I need to read through all these. We've kind of talked about most of these. And then absolute contraindications are these. Now, I know I talked about lymphedema and what are kind of the exceptions. Most of these are pretty reasonable. You'll see cancer is on there, acidosis, excessive swelling post-surgically, or lymphedema. So take a look at those. And if anybody has any specific questions, let me know. Misty's asking, what do you call the dual ply sleeve, to look for them? You can go on Amazon and look, or I buy mine, I think, at Kramer, my sports medicine distributor. And it's called a dual ply, either tensor or, Nick, what is that thing called?
I'm looking it up now. I think we got them through Medco.
Okay, Medco is another distributor. But they come on these big rolls, and you just cut them to length.
Yeah, you have to cut them. They come in these massive rolls. Yeah, I think they're called ProTech. Let me double check.
Yeah, we'll send a link as a follow-up. I'm writing that down. So so far I got to send out review of literature for safety, and then a link for the ProTech. Okay, got it. All right. Any other thing? Sickle cell trait is okay. Anonymous attendee, you're not willing to be there. Wonder who that is. Yes, it's okay. It's just a risk factor, not a absolute contraindication. All right. Choosing a device. So there's lots of choices out there. There's pros and cons to all devices. I mean, you got to think about cost, cuff widths. Do the hoses detach or not attach? How are you going to use it? If you're a swimmer and you want to use it, you're not going to use something that is attached to the pump. You're going to have something that detaches. Reliability of holding pressures. Is there an FDA listing if that's important to you? The length of the cuff, flexibility of the cuff, meaning is it rigid or does it have some give to it? So there's two types of devices to restrict blood flow. There is a practical, which means that it doesn't get inflated. So it just is like a strap or like a voodoo floss band, and you're able to tighten it around the limb. And then there's something called pneumatic. Pneumatic is a type that you're going to inflate with a pump, either an automatic pump or a manual pump. Practical, the ones that we see out there are like elastic bands. People use knee wraps, voodoo bands, straps. Practical, some of the cons, Lonicki and some other researchers have found that you can't really, you don't know how much pressure you're using. You have to kind of guess. In addition, if it's really elastic, it's going to expand, and with muscle contraction, you're not going to trap the metabolites in the limb as much as you would with a more rigid. And then you compare that to a pneumatic. A pneumatic is inflatable. It has a bladder system that inflates. You use a sphygmometer or a pump, and it's typically a little bit more rigid. So let me stop this share, and I'll show you some things about these cuffs. So if you see, here is a number 2 cuff. There's different lengths. So it's really all based on the length of or the circumference of your limb. So if you see, here's our size 3, and then here's the size 2. And you want something that's adjustable, because if you have just one really, really long cuff and you put that on your upper arm and you've got to wrap it a bunch of times, the pressures are going to be higher and they're going to be very inconsistent. And at the same time, if the cuff is too small, then you're going to have a gap, and then you're not going to be trapping the blood that you want it, and how we think that is the mechanism for the gains. So gains. So that's the first thing. Number 2 is, what kind of bladder system does it have? Ours is one continuous bladder. We originally, in our first generation of cuff, made a mistake, and we put in a bladder that was segmented because we thought it was more comfortable the way that it wrapped around the limb. It just created a nicer, tighter. But the problem is, when we tested it, you couldn't trap the arterial flow. And so it didn't fall underneath evidence-based guidelines, and we didn't get the outcomes we were looking for. And so we scrapped it like mid-year. Cost a lot of money to retool it and do everything the way that it needed to be done and the way that the current recommendations are, which is being able to find the amount of pressure necessary and quantify it. And you need a full cup, you need a full bladder to do that. There's a lot of cups on the market that you can't do that with. You can inflate it. You know, if you go on my Instagram and you see a study that was published, I think it was last year, and it compares one of the two pneumatic cuffs. One has a diaphragm that's segmented and it's very narrow, and one has a wider cuff that has a full bladder. They inflated the narrow cuff with the segments like over 500 millimeters of mercury, and they still weren't able to find the occlusion pressure or the total occlusion. Whereas compared to with the wider cuff that has a full bladder, where they were able to find it, you know, within like 140 millimeters of mercury on average. So I think it's important to have a wide cuff, full bladder, something that's cleanable. These have a safety valve on here that you can press if it's too high of pressure. How do we know if it's too high of pressure? You're exercising and your discomfort levels get to above an 8 out of 10. If they're an 8 out of 10, it's too high of pressure and you need to reduce the pressure. So yeah, so we have, our cuffs are 5 different sizes depending on the circumference of the limb. Okay, let's see. If it's important to you, oops, my bad. Let's share again. Okay, if it's important to you to be FDA listed, there's only 2 of us. FDA listing basically guarantees that we are meeting certain standards for safety and efficacy, and what we say we have, we deliver on. There's only 2 FDA listed on the market right now, the Delphi system and our cuffs. Here's your cuff placement. You're gonna go right below the deltoid tubercle, so as high up on the arm as possible. Okay, so that's me applying the cuff. And then up on the thigh, right below the greater trochanter, as high up as possible. These are the only 2 places that we recommend, because if you go in an area that like around the elbow or around the knee, the nerves and the neurovascular bundle is very superficial or towards the surface. And by putting the cuff on that, you could damage the tissue. Okay, please say again, can you use it with sciatica problem? Thank you. Yes, you can use it with sciatica problem, no problem. The way that I use it with acute lower backs and sciatica is I'm a McKenzie practitioner, so I'm gonna find a directional preference first. I'm gonna get that under control and focus on that. And then once I'm able to get their pain levels down to below, let's say a 5 or a 4 out of 10, get the symptoms centralized to the lumbar spine, I'm gonna start a walking protocol with BFR, and then I'm going to start doing other things in order to you know, do my normal kind of rehab from there. Where do you measure circumference? Same places that we just said, right below the deltoid tubercle, right below the greater trochanter. Can this be used? And I also think that I put a link in my YouTube channel of where to measure. Can you be used on lower limbs while swimming? I'm not gonna go through protocols on swimming. That's part of our programming performance, which I will release probably in about 2 months. But there are programs and there are numerous studies out there looking at swimming protocols. Can you talk about BFR and calf strength? I'm not quite there yet. Jan, for the SmartCuffs, if you're using a cuff that is slightly larger than the circumference of the limb, i.e. you use size 3 compared to a size 2, will that increase the risk of arterial or nerve injury? The limb is at the end range of size 2. You're gonna have to use more pressure to get occlusion to find the LOP. I don't know, I don't think with the width of our cuffs, you're going to get any nerve injury. I would start on the lower end of pressures to see how they respond. But when you have a lot of overlap, and let me just stop my share so I can answer this.
Ed, if I can jump in there on this one.
Yeah, go ahead.
I've never seen somebody use a size 2 in the lower extremity. So make sure the cuff bladder is fully enclosing the limb. The strap does not count. So a size 2 in the lower extremity is going to be way too small. The smallest you'll see in the lower extremity would be a size 3. The most common is a size 4.
Yeah, so if I take a size 3, this is a size 3, and I put it on my upper extremity, you're going to see there is a ton of overlap, and I'm not going to be able to get this, I'm not going to be able to get it tight. You're going to be able to, before you even inflate it, I mean, I can get numerous fingers underneath here. The way that I teach it is you shouldn't be able to get more than one finger in between the cuff and your limb before you inflate it. You want it as tight as possible. So that's a size 3. Clearly it's too big. Here's a size 2. So I put the cuff on. Now I've got it on. I can get one finger underneath, but I can't get 2 fingers underneath. That's a good size. That's a perfect size. Typically you're going to be size 2 in the upper extremity. Now here's a size 1. I really hope this doesn't fit, but it's my own issues. Okay, so then now if I go size 1, what you'll see is that I can't get it closed. There's that little gap right there. I don't know if you guys can see. So you see how there's a gap? There's no overlap. Metabolites and venous blood is going to flow up from there. So this is too small. So it's best to use, I mean, if you're using a cuff that's too large, it's better than using a cuff that's too small. But you will have to use more pressure. But I don't think you're going to get nerve injury because of that, unless it's just, crazy pressures. Okay. Okay. All right. How much pressure do we need? Well, in my opinion, you need is the least amount of pressure necessary to get the outcome you're looking for. More is not better all the time. So you want to first find the limb occlusion pressure. And the reason that you want to do this is it's going to quantify how much pressure to use, have reproducibility, and all of the current research is recommending getting an individualized limb occlusion pressure for safety and efficacy. So LOP is the minimum pressure needed to sufficiently occlude deep arteries and the superficial vein. So notice that it's the veins are more superficial. They're more towards the surface. Those guys are going to be easy to occlude. You're going to find that with almost anything. I mean, Macho Man Randy Savage of the WWE would put, bands around his arms and he would tie them up and you would see these great veins and he was getting, venous occlusion. That's why the veins got so big. That's why when we use a rubber tourniquet and before we do IVs or blood draws, you're seeing the veins pop up. You're occluding venous blood flow, and that's going to allow the pooling of the blood below. But to get to arterial, which is really the benefit of BFR, where we're decreasing the amount of oxygenated blood into the limb, you've got to have pressure that is adequate to do that. The way that we do this is measured through a Doppler. In the upper extremity, you're going to find the radial pulse. In the lower extremity, you're going to find the dorsalis pedis or the tibialis posterior. So if you go to the handout, you can see the video on choosing a device. You can see a video on applying the cuffs. And you can also see a video that I gave you on establishing limb occlusion pressure. And so that's going to be the most evidence-informed, quantifiable way, whether it's an external Doppler like this, or it's an internal Doppler inside of a pump. The Delphi system has an internal Doppler. It's really, really cool. It auto-inflates. Problem is in order to get started, it's about $6,000 for a single cuff. So it's usually reserved for very high-end clinics. It's going to be used in a lot of the pro teams, universities that have a lot of money. But the con to that is that the cuff does not deflate, doesn't detach. So we were trying to come up with something that was able to detach and keep price down. And so that's why we decided to go with the handheld Doppler. So this is how you are finding, here you can see her in a seated position. I'm finding dorsalis pedis. You're able to quantify the pressure, adjust the needed based on the patient tolerance. The cons, there's a little bit more cost associated, and there's a time associated with learning how to do it. Now, you don't have to do it every single time. You can do it about once every 3 weeks or so. Every 4 weeks is probably reasonable because your body is going to adapt to the training, so you should reevaluate about every 4 weeks or so. Danielle, the handout was emailed to you, or it's also in the top of the, in the chat, there was a link provided.
I just sent it to her, Ed.
Cool, thanks. Okay, so LOP recommendations, perform it in the same position as you're exercising. So in this case, I'm testing tibialis posterior, and she's in a standing, so she would do standing exercises, walking, squatting. The differences in LOP are pretty dramatic from standing to lying, and a little bit less so in seated. If you go to my Instagram account and scroll through, you'll find an infographic that I made of the averages between seated, standing, and lying down. If you don't have a Doppler, which I totally get if you don't want to invest in more technology, and you're using it on yourself outside of a clinic, because the current clinical medical recommendation is getting personalized pressures. You have to use a subjective scale. There's no other way to do it. And what they have found is that if you're using less than 7 out of 10 discomfort, like on a perceived discomfort, you're probably not going to get the outcomes you're looking for. You should never go above an 8 out of 10. So I use the subjective scale and I use the pressures. So this is how it kind of looks like. I find my LOP with my patient. I'm going to use a percentage of that LOP to exercise in. And then I tell my patient, hey, if your pain level or discomfort level gets above a 7 out of 10, you got to let me know and I'm going to deflate the pressure. And so everybody understands where we're going. How much pressure is enough? Okay, so if you don't have a Doppler, it can be a little faster. It's less expensive, but you can't quantify the pressure and you can't adjust the pressures as you go. Like if he starts to have too much discomfort with the Voodoo Floss band here, I have to just detach that whole band. He can't finish the set. So you don't, but with our cuffs, you can just hit that little button and you get a decrease in the inflation pressure for safety and convenience and comfort. How much pressure is enough? Again, there's going to be some variables. So people that are bigger, you're going to find bigger LOPs, more muscular, bigger LOPs, legs, larger LOPs. Systolic blood pressure is higher, you're going to find a higher LOP. Race is going to change it. Gender, body position, hydration levels. If you don't have a Doppler, if your device will not measure LOP, then you're going to have to kind of guess a little bit. And so here's the best estimate that I can give you. About up to 16 inches, you're going to use between 120 and 160 millimeters of mercury. Between 16 and 22 inches, you're going to use about 150 to 180 millimeters of mercury. And 22 and greater, you're going to use 180 to 300 millimeters of mercury. And again, what I said was these are very, very rough estimates. You're going to have to start low and gradually increase over time, which is not a terrible thing, in order to find where their tolerance levels are and how much pressure you need, and then document and then keep increasing the pressures till you get to that 7 or 8 out of 10. So I know there's going to be questions, so I'm going to take them. If you're using the subjective scale without LOP found, then do you inflate to where the patient is already at a 7 or 8 out of 10 before starting the exercise, or throughout whole session reps? That's a great question, Brian. I would start them at about a 5 discomfort. I would start off with these pressures lower, like 120, 150, 180, and see where their discomfort levels get. And then I would adjust it by inflating to get them up to that 7 or 8. So start it low and increase it. But if you start already at an 8 out of 10, once they start exercising, it's going to go way up above that. How does cuff width affect LOP? Wider cuffs, you get decreased pressures to find LOP. There's some studies looking at improved hypoxia. There's also increase in comfort. Cons, if it's too wide, like why don't we just make a cuff that's 10 inches wide? Well, if we do that, then it's going to interfere with joint movement. And there's some evidence that if it's too wide, it might blunt the muscle protein synthesis effect directly underneath the cuff. So we can't be too wide. We can't be too narrow. It's kind of like Goldilocks. It's got to be just right. All right, so there's a study looking at tissue hypoxia. Here's a study looking at wider cuff is more comfort. And again, here's that reference for practical pneumatic with the inches and how much pressure. Okay, so just as a summary, if you're doing practical BFR, look for about a 7 to 8 out of 10 discomfort throughout the exercise. If you're using pneumatic, use an upper extremity pressure of 40 to 50% of the LOP. So if I have a 140 millimeters of mercury limb occlusion pressure in the upper extremity, I would train at 50% of that or 40% of that. If in the lower extremity, I have a 200 millimeters of mercury LOP, I would use 60 or 80% of that or something in between there. Okay, so let me show how this works. Okay, so here's my Doppler. And you're only going to be able to hear it because I'm going to find my radial pulse. So you hear the pulse. Now I would just inflate the cuff until that pulse disappears. And then I know that I'm right at that LOP. Sometimes I overshoot it, so I inflate a little bit beyond, and then I release the valve until it starts to come on again, and then I use something in between, maybe 1 or 2 millimeters of mercury above where the pulse came back on. So using the Doppler makes it a lot easier. After I've established LOP the first time, if it's loud, you don't have the Doppler with you, and I document what the LOP is. So I document in my notes, hey, this is the personalized LOP. I did it in a standing, a seated, and a supine position. I used a Doppler ultrasound. I used this cuff. And then what I would do is, if I need to, I can always retest it taking a pulse or other means of doing it. And once that pulse disappears, it's going to give you a good estimate. But you want to know where that LOP is and have it in your notes as a standardization to move forward from. Hopefully that makes sense. Okay, so on the workbook, we're going to talk next about kind of programming. All right, so if we want to get strength and hypertrophy, again, we started off with the goal of what's our goal? And if our goal is to create size and strength, we're going to use between 20 and 40% 1 rep max. So how do we know that? Well, we can get it, especially in a healthy individual. A lot of times my CrossFitters will come in and they already know their 5 rep max or their 10 rep max. So then I can estimate it, which I'll show you how to do. Sometimes people come in and they're injured and I don't know. I would just use the same resistance that you would normally use. So if you use TheraBand, if you use the resistance, if you use body weight, just use the same exercise resistance as you normally use, because that's going to be light intensity load. Each exercise composed of 4 sets, 30, 15, 15, 15, with a 30-second interset rest. You're going to keep the cuffs inflated throughout the whole exercise. So this is what it's going to kind of look like. If I'm doing a modified push-up, I'm going to inflate the cuff to my desired pressure. Typically in the upper extremity is going to be between 40 and 50% LOP. I'm going to perform 30 perfect repetitions. I'm then going to rest for 30 seconds. And then I'm going to perform another 15 repetitions. And then I'm going to rest for 30 seconds. I'm going to perform another 15 repetitions. I'm going to rest for 30 seconds. I'm going to perform another 15 repetitions. And then I'm going to deflate the cuff and I'm going to move on to the next exercise, hopefully within a minute. I don't want to keep those cuffs deflated too long in the same body region because I want to try to capture the metabolites that are accumulating distal to the cuff. Let's see. Have I noticed any major differences, increases in LOP with chronic BFR? And the answer is, I don't know what major is. You get differences because you get hypertrophy. So when the limb starts getting larger and your capillarization or angiogenesis is occurring, you're going to see changes in LOP over time. So the answer is yes. Do you always do a single movement for your 30, 15, 15, or can you set up a circuit? How would you like to set that up if so? Ooh, circuit. I don't really do circuits. Wow, that's a really good question. That's something I'm gonna have to think about because I haven't done a circuit with, but you kind of have to break in between and the reps and everything are gonna be different. You could do a circuit, but you would stay at the same exercise for the exercise. So you would do 30, 15, 15, 15 for modified push-up. Everybody would deflate, then they would move on to the next exercise, they would inflate, and then they would do whatever's next. That's about the best way I could tell you to do circuit training without thinking about it a little bit further, because otherwise you're going to be all messed up with the 30, 15, 15, 15. Now, there's a lot of programming that includes going to failure, and if you're okay with going to failure, meaning that you're going to have more time in between sessions, like 2 or 3 days, you could do a circuit. I just don't think it's necessary. I would do each exercise, and then I would move on to the next exercise to keep it a little bit easier to follow. And again, here's doing a lower extremity, like a isolated long arc quad. You could add ankle weights if needed, but this is doing lower extremity, same thing, 30, 15, 15, 15, rest, deflate the cuff, move to the next exercise. Here's a compound exercise using lunges. I did get an example about BFR and calf strengthening. Injury risk, no increase in injury risk for doing isolated calf strengthening. I would do seated for soleus. I would do standing for gastroc. And so that way you're doing a combination of both and wear out your type 1 and type 2 fibers in both of those muscle groups. I think I answered this. Okay. Here's your chart for if you're estimating 1 rep max. So if you have somebody that has a 5 rep max, meaning they can do 5 perfect repetitions at a certain weight, you look at the number of repetitions as 5, multiply that weight times 1.15. That will give you your estimated 1 rep max, times that estimated 1 rep max times 0.2 for 20, and that's going to give you your starting training intensity. So in this case, they did a 10 rep max, they did 100 pounds. That is 1.33 times 100 pounds equals 133 pounds. That's your estimated 1 rep max. Multiply that times 0.2, and it's going to give you 26.6 or 27 or 30 pounds is going to be about your starting point. When we do aerobic capacity training, we use something called your heart rate variability. So you're going to choose your modality. Typically, it's going to be swimming. It's going to be bicycle. It's going to be treadmill. It's going to be upper body ergometer. It's going to be anything that you want to use, you can really use. You're going to find your heart rate reserve. I'm going to show you how to do that next. You're going to do 15 to 20 minutes, and you can do this up to 1 or 2 times per day. So here is, look on your worksheet on how to calculate your heart rate reserve. First, you find your resting heart rate. The best way that I can find people's resting heart rate is from their, typically people have, when they come in, one of these, Apple Watch. You can find their resting heart rate. What is their lowest heart rate throughout the night? It's typically where you're going to find it. Oura Ring. You can find your resting heart rate or your lowest heart rate. That's what I would use. Or if they're just in the clinic and they don't have any of those things, then you can just take it for 1 minute at the carotid or at the radial pulse. Then you're going to take the estimated max heart rate, which is 220 minus your age. It's going to give you your estimated heart rate max. Your estimated heart rate max is higher than your resting heart rate. So you're going to take your resting heart rate, put it in here, and take your max heart rate, subtract your resting heart rate, and that's what number is going to go right here. That's your heart rate reserve. Take your heart rate reserve and multiply it times your intensity that you want to start at. We always start at 30% heart rate reserve, or 40% VO2 max if you have that, 30% times your heart rate reserve, add back your resting heart rate, and that's going to give you your target heart rate. So this is how it kind of looks like. I inflate the cuff. I've got my heart rate monitor on, or I've got my watch on, and I look at what that heart rate is. I jump on the treadmill. I elevate the treadmill to 1 incline. That mimics being outside with wind resistance and things like that. I start the speed and I slowly start bringing it up. Maybe I go to like 1.5 speed, miles per hour. I give it a minute or so for the heart to catch up. I look at the pulse. If I'm not at that target heart rate yet, then I increase the speed by about half a mile per hour increments until I get to the target heart rate. Once I get to the target heart rate, the time begins. So then they're going to start their 20-minute walking or cycling or whatever session. The more that you get to that point of knowing where their heart rate reserve is, how much resistance, the easier it gets. The first time is kind of trial and error. Jan asked, the handout says perform multi-joint exercises prior to single joint. The rationale behind that is multi-joint exercises typically take, they don't fatigue out, or the multi-joint exercises fatigue out the central nervous system and the peripheral nervous system faster. They also require more motor control. So if I start somebody with, let's say, a long arc quad, and I fatigue all your type 1 muscle fibers in your quad, and then I jump to a harder exercise, a multi-joint exercise, you're not going to be able to manage your squat. You're not going to be able to manage your form. Whereas if I get you fresh, I do the multi-joint exercise, and then I fatigue out with isolated exercise, something that's simpler on the nervous system, simpler within motor control and motor movement. That's my rationale. And I could see arguments, other ways as well, but that's my rationale. All right. There was a question regarding cuff comparison, so I do have this in here. Here's our SmartCuff price, FDA listing, yes. Doppler included. It is included with the clinical set only. The width of the cuff, detachable hose, made in the USA. Owens Recovery Science. This is actually wrong. This should be, it's about, I think it's at $6,000 now because you have to take the training certification to purchase a single cuff is about $6,000. FDA listed, yes. Doppler included, it's included in the pump. You can't detach the hose. Be Strong, that's another popular option, and then the Katsu system. The thing with the Be Strong, I used to use the Be Strong system. It has a segmented bladder, so you have to use an arbitrary pressure. You can't get limb occlusion pressure. I also don't feel like I get the workout I get with the SmartCuffs or the Owens Recovery because the Delphi system, we're using that. You're not allowing any metabolites to escape. And I didn't go into mechanisms too much here, but part of the mechanisms is not allowing lactate to get to your liver to create more sugar to get to the muscle. And because of that, it makes you fatigue out quicker and easier. And so I think we get better outcomes when you use something that you're able to occlude the arterial flow. Here's what the clinical set kind of looks like. If you use my code, you get a percentage off. This would be perfect for the clinic because you get all the different cuffs. Here's a personal set, which is lower and upper extremity, no Doppler included. And a Doppler you can do as an add-on. And then here is your basic set. You could get one for the upper, one for the lower, or you could do two lower, which a lot of cyclists do. So those are our cuff options. Next week, I'm going to do a lot more for programming. It's going to be a 4-week home exercise programming, something that you could also use with telemedicine, which I'll touch on. Research to support the programming and the waiver that I use in the clinic. I'm going to share all that. We're going to do that on Thursday from 11, and we'll send out a link to register for that if anyone is interested.
I can send it out now, Ed. I got it up.
Okay, cool. Thanks. Tony Groff, if aerobic is rowing, concept 2, yep. Is it recommended or okay to have the cuff on? You know, Tony, I wouldn't recommend getting the cuffs on all four limbs. And the reason is, here's the short of it. Somebody mentioned before about people passing out as being one of the primary risk factors. And the answer is that if you put cuffs on all four limbs and you're truly occluding arterial flow, what's going to happen is your heart rate's going to go through the roof because your stroke volume has been drastically reduced. So it's just, I just don't recommend it. With our cuffs, you can't do it. With some of the other cuffs, you can because they're not fully occluding. I'm not going to mention the other ones because I just don't, I don't want to, I think everybody's doing the best job that they can do with what their philosophy is around the BFR. And this is just our philosophy from an education and programming. And I'm trying to use the best evidence possible to support it. But I would not use our cuffs on all four limbs because people will pass out. Just doing isometrics, I've had people almost pass out. I've had to put them on the table, elevate their feet, give them cool rag. And it's not because I was overtaxing them, it's because it is a lot of work. Hopefully that answered it. So if I'm doing rowing, I would typically do the cuffs. You know, it depends on really what you want to work. I would probably do the cuffs on the legs. I could see why you would want to use the arms if you want it to be more of an upper body, but when you put the cuffs on the upper arms and you do a upper body erg, it's hard to do a long bout. So you might only get 5 or 6 or 7 minutes. You mentioned resistance training frequency 2 to 3 times a week. Yep. What if you do 3 times a week upper and then 3 times a week lower? Wouldn't be going to failure. Really just clarifying if doing upper extremity BFR just taxes upper body versus whole body and vice versa for lower body. Yeah, I would think that that's reasonable, Brian, is to split them up if people want to train every day. You get a little bit of systemic effect, but if you split it up, that would be fine. And what I mean by systemic effect is something proximal to the cuff. So if I have a cuff here, I get benefit distal to the cuff. I also get benefit crossover, but I get benefit everywhere else as well. But everywhere else is not as much as distal to the cuff. So you could split it up that way if you wanted to, for sure. Sean, can BFR be used as a recovery mode after vigorous exercise? The answer is yes. I wouldn't, it's a tough question because with recovery, you don't want to use high pressures. There was one study looking at using BFR after high intensity exercise, and they used high pressures, and it looked like it blunted the muscle protein synthesis effect. So you want to do lower pressures, and you want to do basically 2 to 3 rounds of about, like in the lower extremity, 60% limb occlusion pressure, 5 minutes on, 3 minutes off, 5 minutes on, 2 to 3 rounds max. Thank you for that. Yeah, we'll keep doing more free webinars in the future as well. All right, Rick, sounds good. Looking forward to seeing you. Thanks for attending. Day after competition for recovery. Yeah, I would definitely do it, Nancy, at that point. Then you can do a full cell swell protocol. And you can do a full cell swell protocol after, after training, like after a match or something, for sure. There's no problem with that. Doesn't look like it blunts. Jamie, do you have any concerns with using BFR with high functioning athletes where the muscles are getting these great gains while the ligaments are not receiving the demands needed for sports movements? Yeah, it's a good question. I'm not nearly concerned about the ligaments as I am about the tendons, because just like using anabolic steroids, if the muscle mass gets too big, then what's going to happen? The tendons don't keep in line with the ratio of growth. So what was interesting is in 2019, there was a study looking at tendons, and I talked about this on my, every Tuesday I do a weekly BFR webinar. In that study, they saw tendon stiffness and hypertrophy to match muscle. I think the argument is that with high intensity exercise, if you can do it, you should be doing it. Like my high level athletes, my guys that are training for like the combine, we don't just do BFR getting them ready for the combine. They're doing normal training and using BFR to decrease the volume of high intensity load. So you're always going to use it in combo for that reason. I think we need a validation study on that study looking at tendons, because every other study didn't see that, where the tendon stiffness and hypertrophy occurred in matching the muscle mass. So I think there's more to learn, but it's a very good question, and it's something that we should be aware of. My opinion is BFR does not replace high intensity training. BFR supplements it, and it also allows us to train non-high intensity in times when we can't. So hopefully that answers. Jan, can you talk about doing your personal experience performing aerobic in the morning and resistance in the PM and your rationale behind it? Sure. Yeah, I think most people metabolically, hormonally, and the research supports this, is that you get better results doing your resistance training in the afternoon. In the morning, I'm going to do my aerobic capacity training on an empty stomach with a cup of coffee in my gut. And then I'm going to go do something at a moderate intensity, exposure to vitamin D, hopefully if the weather's nice, by the sun. And it's going to be quick, 15, 20 minutes, 30 minutes max. If I use the cuffs in conjunction with that session, I'm going to get an aerobic capacity effect. If I do aerobic capacity and I do weight training in the same session, this research has shown muscle protein synthesis is blunted. I'm not going to get the effect from that resistance training due to whatever aerobic training I do before then. So I separate them. If you can't do 2 sessions in a day, I would split them. Aerobic one day, I would do resistance the other day. It's about the best I think we can do. We haven't seen any studies with BFR comparing, doing aerobic and resistance. At least I haven't seen it. So there's more to learn, but that's my rationale for splitting it. It's hormonal, it's metabolic, it's separation, it's what's in my body, especially if people intermittent fast, all those things. Thank you, Mitchell. I appreciate it. Glad you were here. Musculo, can you talk about any musculo condition? I'm not sure what that means. Try to clarify that for me. When can you safely initiate following total joint orthopedic surgery? Matt, total joint, no contraindications. Again, it depends. If it's a shoulder, you can't put the cuff right over that replacement for probably 12 weeks is what I'm going to guess. Maybe 8. I would get with the surgeon about that. But if it's like a knee, you can start with no contraindications right away. If it's a hip, you got to wait. You can't go over that incision site with the cuff. Also with the high-level athletes, any instances of high-level athletes having abnormally high? No, like they won't test positive for anything abnormally high. I think there's a group of us that work in pediatric orthopedics that are interested in using this with our patients when we see them for things like ACLR. Sure, yeah, we're starting to see this younger and younger. Yeah, I know, it's terrible. And they're not elite athletes. Do you mind elaborating on your thoughts and using this in this population? Yeah, my hesitation, Caitlin, is mostly on the lack of research and that we just don't know. And, for most of them, is it important? Is it so important that we get them back 3 or 4 weeks? Well, in your case, you're saying 12 or 13. I think I would get, I personally don't think anything is going to occur from this. I think that what you need to do is have a consent signed. You need to have a conversation with the orthopedic surgeon and get them to sign off on it, and the parent and the athlete. I think it's got to be a 4-way communication. It's just because we don't know. We don't have the answer. And I just don't know what I don't know. It's my blind spot. Hopefully that helps. No considerations that come to mind. Nancy, yeah, absolutely. You can cuff up. You can do resistance training twice a day. There's been studies looking at doing resistance training as long as you don't go to failure because you're not causing any muscle damage. So you can do double sessions if you wanted to. Not many people will, but I would split aerobic and anaerobic. All right, that looks like, sorry, Sandy, but if you have any other questions, just shoot me an email or on social media. I'm not sure what this means. All right, looks like questions are over. We're starting to lose everybody. You guys, thank you so much. Look forward to that class next week if anybody wants to join. If you have any questions, feel free to hit me. Otherwise, please follow me on social media, especially Instagram. That's where I'm trying to build, and YouTube. And look out for a couple of emails. I promised you some things. In addition, my Tuesday BFR webinar every Tuesday at 12. And then I put the replays up on my YouTube channel. Thanks so much. Appreciate it. And be safe and be well out there in this crazy, crazy time. Bye for now.